In this video, I will be reviewing the epidemiology of COVID-19, how this virus spreads. And this infection is primarily spread by respiratory secretions. Close contacts can inhale droplets associated with coughing, and the droplets can land on surfaces where they can survive for hours up to 3 days. Droplets usually do not project beyond 2 meters or 6 feet when someone speaks or coughs. However, a powerful sneeze can project droplets longer distances. Also, singing and certain procedures such as intubation can produce aerosols, the fine, moist particles containing virions that can remain in the air for up to 3 hours. They are less than 10 microns in diameter. Recent studies now find that asymptomatic or pre-symptomatic individuals make up a very significant percentage of cases. On the Diamond Princess cruise ship, over 600 individuals had positive tests for the virus, and 18% were asymptomatic. Recent studies now estimate that 40 to 60% of those that are infected are asymptomatic. Children and adolescents are more likely to have minimal symptoms. There are also reports of super spreaders. One of the most notorious examples is Case 31 from South Korea. This 35-year-old Chinese woman traveled to Wuhan, China, to Daegu, South Korea, where she visited a megachurch twice, as well as a hospital, and while febrile, ate at a buffet before she was diagnosed. Tracing determined that she had come in contact with 1,160 people. The virus can also be found in stool, but it is difficult to culture, and no cases of transmission by this route have been reported. To date, perinatal transmission has not been observed. Tracing studies reveal that an infected host can infect 2.0 to 2.7 others. This number is termed the R sub 0, or R naught, and this virus is one of the most highly infectious agents ever reported, and its efficiency of spread varies depending on the degree of crowding. For example, in New York City, the R sub 0 before shelter in place was found to be 5.0. The majority of cases are acquired by close contact of a symptomatic person. Current estimates are that 10% of close contacts develop the disease. 80 to 85% of infections are contracted within the family, called family clusters. Other settings have included the megachurch in South Korea with over 1,200 cases, cruise ships, sporting events, and an entire Italian community. In the early phases of the epidemic in both China and Italy, a large portion of nosocomial or hospital-acquired transmissions occurred through contacts between clinicians and visitors with no or mild symptoms of COVID-19. A number of healthcare professionals also contracted the virus in New York City. In addition to doctors and nurses, support staff who were not provided with adequate PPE became ill. Healthcare professionals must beware and remember Dr. Sisi. I will be discussing how caregivers can protect themselves in the fourth video. When it comes to who is infected, this virus is an equal opportunity promoter. Everyone appears to be equally susceptible. Every age, including young children who may have mild symptoms and be interpreted as having another febrile illness, can become infected. Males and females are infected with nearly the same frequency. Our understanding of how the virus infects humans is described in the first video and is supported by the studies of viral counts in the nasopharynx and throat over time. Soon after being infected, before symptoms develop, as well as during the first 24 to 48 hours of symptoms, the counts are very high, and patients are most infectious. Some individuals shed the virus for over 2 weeks. The outbreak of COVID-19 began as a point source in Hunan live animal and fish market, and the majority of cases were among market workers. However, within 10 days, the disease had rapidly spread to person to those who had not been in the market, demonstrating early on that this virus was highly infectious. These maps document the rapid spread throughout China. Each 10-day interval documents the spread outward from the city of Wuhan, where the market was located, into the entire Hubei province and progressively into the other eastern provinces. The infection quickly spread throughout the world as a consequence of Chinese citizens traveling to Europe, particularly to northern Italy. And tourists infected while visiting Italy then spread the virus to New York City. As shown on this map from the Center of Systems Science and Engineering at Johns Hopkins, as of May 20th, there have been nearly 5 million cases and 324,000 deaths, with a death rate of 6.5%. To better illustrate the importance of early intervention, I commissioned the famous artist and family friend Bruno Lucchese to draw an image of Pandora's Jar. Zeus, angered by the deceptions of Prometheus, warned that a great plague to you, yourself, and to men shall be. He created Pandora, a beautiful maiden, and fashioned a jar, often mistranslated as a box, containing all the pestilence of the world. He encouraged the curious Pandora to open the jar, releasing a plague on all men. 3,000 years later, we are now experiencing such a plague in the form of COVID-19. And when politicians delay applying the tools of infection control, they are leaving Pandora's jar open, allowing the virus to spread, causing unnecessary suffering and death. These are epidemic curves for South Korea, China, and all the European countries, including Italy and Spain, the Scandinavian countries, Australia, and the US. The vertical axis is a log scale of the number of deaths per day from COVID-19. Each star represents the time at which the government implemented shelter in place, that is, when they closed Pandora's jar. Look at South Korea. They implemented shelter in place and aggressive diagnosis of cases and case finding and isolation after observing 3 deaths per day. Note the nearly flat curve for South Korea, pale blue. Also notice that the number of cases has dramatically dropped in China, the orange curve. They intervened after 3 to 4 deaths per day and after a total of only 30 deaths. Italy, the black curve, and the highest star, on the other hand, waited until the daily death rate was 75, and they had accumulated a total of 800 deaths before ordering shelter in place. Note the steep curve as a consequence of leaving the jar open. Italy has had the highest number of deaths of any European country. Finally, note the steep curve for the U.S. in red. The U.S. did not implement a uniform policy. Some states sheltered in place, others choosing not to intervene. The consequence of this approach, we have by far the largest number of active cases in the world, representing 1/3 of the total cases in the world, and the U.S. has experienced 4 times the number of deaths of any other country. To make matters even worse, we are now reopening up those states who chose to shelter in place. Here is a U.S. map for May 20th from the Center of Systems Science and Engineering. As compared to earlier maps, the entire nation now is covered with red dots, indicating significant numbers of cases in nearly all states. New York City has the largest number of cases at nearly 194,000. Chicago is second with 64,000. Los Angeles third with over 39,000. Detroit fourth with 25,000. Miami fifth with 16,000. New Orleans sixth with nearly 14,000. And finally, Seattle, the city that in an early phase of the epidemic had the most cases, but now is one of the lower numbers with 7,500. Because I practice in Florida, I wanted to share the latest predictions by the Imperial College. They have analyzed every state in the U.S. with regards to R sub 0 and find that those in red continue to have an R sub 0 of greater than 1. Unfortunately, Florida falls into this category with an estimated R sub 0 of 1.2. In the next set of graphs, the far left graph shows the number of deaths per day in Florida peaked in late April with nearly 90 daily deaths. As of May 18th, there have been less than 50 deaths. The middle graph shows the number of new cases per day that peaked in early April at approximately 6,000 cases per day. On April 6th, shelter at home was ordered. However, 1 month later, in early May, the governor ordered a phased reopening. Note that the number of daily cases has been steadily rising since shelter in place was rescinded. In the far right graph, the change in R sub 0 over time is shown. The value was less than 1.0 in mid-April, but upon discontinuing shelter in place, the R sub 0 has climbed to 1.2 by mid-May. This final set of graphs shows the Empirical College's predictions for the daily death rate in Florida as mobility increases. That is, as people go back to work and return to stores and restaurants. If people maintain the low level of mobility of shelter in place, the daily death rate will stay in the 50 range. If mobility is increased by 20%, the daily death rate will increase to the 300 range by early July. And if the residents of Florida increase their mobility by 40%, the death rate could reach 1,000 deaths per day. To summarize the content of this video, transmission is predominantly by droplets and aerosols. Contaminated surfaces are likely to play a minor role. Beware of the asymptomatic carrier. Rapid spread from person to person occurs predominantly in families and less commonly spread through large gatherings and cruise ships. The R sub 0 or R naught is 2 to 2.7. The epidemic began as a point source outbreak in the live animal fish market in Hunan, China. As of May 20th, the cases continue to rapidly increase worldwide with nearly 5 million cases and 324,000 deaths. Many countries have experienced exponential epidemic curves that are now leveling off. These steep curves were the result of delays in implementing infection control practices. They left Pandoras Jar open. Testing, case finding, and isolation are critical for controlling the spread. However, many countries are failing. Exceptions include China and South Korea. The United States failed to consistently implement appropriate infection control measures, and we now lead the world in active cases and deaths due to COVID-19.